of HER2 positive breast cancer. This session is sponsored by Roche and Lalpath Labs. With that, it gives me great pleasure to introduce our chairperson, senior medical oncologist, Dr. S.H. Advani, who's also a recipient of the Padma Bhushan and Padma Shri in the field of cancer treatment. His hospital affiliation is at Shushruth Hospital, Mumbai. With that, I welcome sir to please start the proceedings. Over to you, sir.
Yeah. Good evening, colleagues. I think we are really very happy to be here together to discuss on a very important area, which was unknown 25 years ago. We never knew what is HER2 positivity. And since then, since the information and the knowledge came up, and then we realized that this can be the driver mutation or the target, which can be targeted to control the disease. And that was a great sort of a change in attitude which came up in the breast cancer, that we started talking about targeted therapy. And I think the first one was the monoclonal antibodies, the Herceptin. All of you know that how it came up and how it changed the whole horizon of the management of the HER2 positive breast cancer. But I must admit that since then, there have been further development in the in order to control the disease better, in the sense that there are multiple ways that we can control the HER2 molecule and inhibit that. And you can see over here that how over a period of time, new and new drugs have come up. Initially on the Herceptin, then came up, of course, the double targeted therapy, the Herceptin and Perjecta, and then came up the drug antibody conjugates like Kadcyla. But it has not really stopped at that. And now we have got the other drugs as well, like we have a HER2, which is supposed to be even effective after the failure of Kadcyla. Apart from this, I think we have also the oral drugs, which can control the HER2 positive breast cancer. One of them we have been using for long has been the Lipatinib. But I think now better drugs have come up like Tucatinib. And that's a wonderful tablets which can not only control the disease systematically, but also in the brain. So I think with these few words, I would request my colleagues to really go ahead and discuss all the important areas of the HER2 management of HER2 positive breast cancer. Thank you. Dr. Shivam and Dr. Boman will continue the whole session.
Thank you so much, sir. With that, it gives me great pleasure to introduce our first speaker, Dr. Shivam Singla, medical oncologist from Fortis Hospital, Mahim, Mumbai. And he'll be talking on the topic, Transform the Journey for Your HER2 Breast Cancer Patients. This session is sponsored by Roche, and I welcome Shivam, sir, to please deliver his lecture. Over to you, sir.
So I thank Roche for the opportunity, and I also congratulate Kavina Creations for creating this fantastic meeting. So I will be sharing my slides. Just let me know if you can see them.
Not yet, sir. Yes, sir. Now we can see your screen, sir.
Yeah. So good evening, one and all. Today, I'm going to speak on transforming the journey of your HER2 positive breast cancer. I have been fairly young in practice, but I've seen HER2 space completely changing its structure in front of our very own eyes. These slides have been provided by Roche to me, so please let me know if there is any contraindication or any thing that comes out. So today we have seen, as Sir has shown, that how a space of HER2, there are a lot of drugs which have come up. When I talk about specific to pertuzumab and trastuzumab, they have been the backbone of transformation, this transformation journey. There have been three basic settings in which these drugs have been required. The first has been the neoadjuvant settings in early breast cancer, and that pivotal study was Neosphere trial, which showed that there's an 18% improvement in the PCR rates by addition of pertuzumab to the ongoing treatment with trastuzumab. And then this was again consolidated with the studies with Trifina, Berylliance, and Pionetral. In the adjuvant settings, there have always been inconsistencies to which patients benefit, but we know that node-positive patients, pertuzumab reduces the risk of recurrence or death, significantly. And this was initially, came to our knowledge with the affinity trial. In a metastatic setting, all of us, all medical oncologists know that getting a pertuzumab or a dual blockade leads to an improvement in overall survival, also in the progression-free survival. So as of now, a combination of pertuzumab and trastuzumab is approved with chemotherapy in all the clinical settings. Now, when we look at a HER2 positive disease today, early breast cancer, it is very important to use an algorithm because there are multiple agents which are available today. And we would end up getting confused if we're not following an algorithm. So this is one of the algorithms which is approved by European and American societies, and that is what we also practice, that majority of our patients with HER2 positive disease would undergo neoadjuvant chemotherapy until it's a very small T1C N0 disease. Now, a patient who undergoes a neoadjuvant chemotherapy post-surgery, we would either attain a PCR or we would be left with the residual disease. In case of a residual disease, we go with the TDM1, which is now being accepted as standard of care. But when the patient achieves a PCR or is node positive on an upfront surgery, these patients are required to take a pertuzumab trastuzumab combination for a year. Now, this is where the trouble of the patient starts. We know that IV treatment is well established, but there are certain challenges. First, these patients are fed up with the long infusion times, and especially when we work in Indian setting, the getting up of the clearances from the hospital setups, during the COVID times, doing an RT-PCR, and a lot of the hospitals are still following that practice. The overall time period of a patient for a pertuzumab trastuzumab combination goes above 2 to 6 hours. The challenge is the resources are limited in every setup, and we are always struggling for occupying the chemo bed. Placing an indwelling catheter or putting a IV line is a challenge, especially in a patient with breast cancer where we cannot use one arm. And again, with the port and other PICC lines, we're increasing the thrombosis or discomfort to the patient, the risk of thrombosis or discomfort. When we look at FESGO, the best advantage that subcutaneous combination brings to the table is that it contains both the drugs in a subcutaneous form. It is combined with recombinant human hyaluronidase so that there is no swelling post injection, and the hyaluronidase really breaks up the subcutaneous matrix, and there's a uniform distribution of the injection. But the biggest advantage is that you are substantially reducing the time of patient exposure in the hospital. It can be administered over a period of 5 to 8 minutes. The fixed dose combination, the mechanism of action is nothing new. We've all known how this dual HER2 blockade works in both preclinical and clinical data. But what is important is that hyaluronidase increases the dispersion of the drug. So there is no collection of the drug locally, and there is no swelling and reducing the side effects of the drug. The effects of hyaluronidase are reversible, and permeability is restored after 24 to 48 hours. Again, no long-term implications. When we look at large volume fluids, if you would to inject the hyaluronidase injection, without the hyaluronidase injection, the skin cannot tolerate more than 1 ml of subcutaneous fluid administration. But the addition of hyaluronidase to this combination results in more dispersion of the fluid without any added side effects. After subcutaneous disruption, the skin architecture is rapidly restored to normal within 1 to 2 days. This is one photographic example of the drug, how hyaluronidase reduces the swelling. This is 10%, 10 ml of IgG solution which has been injected in the arms of this fake patient. You can see that without hyaluronidase, there's a big lump. But if the hyaluronidase was given, there is a uniform dispersion of the drug in the subcutaneous tissue. Now, briefly, I would take you through the development of the FESGO as a product. The first trial was the dose finding trial, that was BO301885 trial. Then FESGO went ahead. There were recommended doses, a loading dose of 1200 pertuzumab, 600 trastuzumab, and a maintenance dose of 600 pertuzumab plus trastuzumab, followed by the efficacy, the Federicia and the Farnesia trial. The Farnesia trial was the trial where we looked at the patient preferences of the particular drug. So this is the trial design of the BO 30185 trial, where the study was the dose finding study. I just share with you briefly the summary of this trial. This trial suggested that a loading dose of 1200 of pertuzumab and maintenance of 600 pertuzumab was adequate for the trough values. The data was comparable to the IV form of 840 mg and 420 mg respectively. The safety, there were no safety signals that were flagged in this trial, and the further studies were supported in the subsequent trials. When you look at the Federicia trial, this trial was basically in the new adjuvant setting where all high-risk patients were subjected to investigator's choice of treatment in dose-dense AC versus 3-weekly AC, followed by paclitaxel plus pertuzumab plus trastuzumab in the IV form versus subcutaneous form, followed by surgery, followed by an option of both and a long-term follow-up. The primary endpoint was non-inferiority by cycle 7, pre-dose cycle 8 trough values. And when we look at this data, this was very reassuring that the drug met the primary endpoint. The subcutaneous version had slightly higher trough values of the drug as compared to the IV form. So this is the trial findings which suggested that the pertuzumab plus trastuzumab fixed dose combination subcutaneous was non-inferior to the IV form based upon the pre-cycle 8 serum trough concentrations, where you can see that in the primary serum trough concentration, the values were 88.7% versus 72 in the IV form. Again, it almost had the same pathological complete response rates. What is important was that in all subgroup of weight population, the underweight, normal weight, overweight, and obese, the results were pretty much similar, and there was no statistical difference in the overall population also. In terms of adverse events, the safety profile of subcutaneous version was comparable to the IV form. There were no additional red flags. The adverse events were balanced between the two arms. The incidences of adverse events were consistent with the other studies in the other trials. In terms of hypersensitivity side effects or cardiac dysfunction, again, no difference. Numerically higher incidence of diarrhea, but not statistically significant in terms of all the drugs. Just a second. Yeah. So there was no difference in the cardiac safety between the two treatment arms. So how was the trial concluded? The subcutaneous form was non-inferior to the IV form in terms of in terms of the trough level concentrations. The total pathological response rates were similar in both the subgroups, and the safety profile was comparable in both the formulations. Now, what is the patient preference? I think the Farneska trial was designed to identify what would the patient prefer, a subcutaneous versus an IV form. A simple trial design, early breast cancer patients who have completed neoadjuvant therapy. There was a crossover which was allowed by the patient's choice of subcutaneous versus IV, and the treatment continuation for total of 18 cycles. Up to fairly strongly, 93% of the patients, majority of the patients felt that subcutaneous was their treatment of choice. The main reason was less clinical time and more comfortable during administration. Up to 87% chose to continue the subcutaneous form throughout the course of administration. Again, treatment had no impact on the patient healthcare professional speaking time. In fact, in the subcutaneous arm, the interaction was even higher. And most patients had more than enough time to talk to their healthcare professionals during the subcutaneous administration. When we look at the majority of the findings that why it was switched from an IV to subcutaneous form, that in majority of the IV forms, the time in the treatment room was much higher, up to 6 hours, as compared to 33 to 50 minutes in the subcutaneous arm. And the nurses, they had lesser time, they took lesser time to prepare the drug, 8 minutes versus 150 minutes in the IV arm. When we look at the Franesca adverse event rates before and after, they were similar. There were no new safety signals in terms of injection site reaction or diarrhea or fatigue or hot flushes. So, the lessons learned from Franesca trial was that the patient preferences were towards a subcutaneous form. They were lesser time in clinic. They were more comfortable during administration. More patients were satisfied. They had more time to speak to their doctors. It led to a lesser burden on the healthcare system, and the safety profile was well balanced in terms of the drug. So, what are the practical considerations in the real world when the patient is, arrives into the clinic? We have to make sure that the patient is comfortable on a recliner. We ask the patient to, sit up straight, have a resting position. What is important is that this injection is never given in the abdomen, so we would end up using the limbs. We have two syringes given with the injection. The one syringe is for withdrawal in the injection, and one is for the administration of the injection. Try to choose a healthy site which is not bruised, tattooed, because you would not be able to understand the after events. The tips to administration is how we give any subcutaneous injection is to pinch the skin, make the needle at 30 degrees, and try to give it slowly, over a period of 8 minutes, and keep an observation of 30 minutes in the loading dose, and try to give it over a period of 5 minutes and keep an observation of 15 minutes in the maintenance dose. In terms of post, administration, the doctor, depending upon the hospital outpatient, dosage can be administered in a dedicated area, or you can have a room where the patient and the doctor can physically talk to each other. The drug can be administered both in a chemotherapy daycare or in the outpatient clinics. We generally give a blanket on top of a patient to make them feel less exposed. So, what could FESGO mean? Is it more for the patient? Is it more for the healthcare professionals? I think in my practice, what I feel, I am able to spend more time with my patients, and there's lesser burden on the healthcare system and the hospitals. It's also cheaper for the patients because of the ongoing program given by Roche for the patients. So when I summarize this talk, I think this is very easy and no-brainer that it is a shorter duration of action. It's a less invasive form of administration. It reduces the risk of dosing errors. It doesn't require much time to prepare, and there are no safety signals, and the effects and the side effects are pretty much same. That is what we had seen with the two Fredericia and the Franesca trial, that the rates are same and the patient administration is towards the FESCO. So with this, I would like to stop my talk and hand over the mic back to the administrator. Thank you so much for giving this opportunity to me.
Thank you so much, sir. We now move on to our panel discussion. Our moderator for the session is Dr. Boman Dhabhar, who's the director at Just Look Hospital and Research Center, and he's also the director at Fortis Hospital, Mulund, Mumbai. He'll be talking on the topic, Transform the Journey for Your HER2 Breast Cancer Patients. And his panelists are Dr. Tejender Singh, medical oncologist from Apollo Hospital, Mumbai, Dr. Nikhil Pandey, medical oncologist from HCG Hospital, Nagpur, Dr. Shivam Singla. So we request you to also join the panel if possible. Dr. Prabhat Bhargava. Perfect, sir. Thank you so much. Dr. Prabhat Bhargava, medical oncologist from Tata Hospital, Mumbai, and Dr. Satyajit Pawar, medical oncologist from Dinanath Mangeshkar Hospital, Pune. So with that, I hand over the mic to Dr. Boman. Over to you, sir.
Invitation, and the question will be to any one of the oncologists of any of our panelists. There is nothing like any one of you can just pick up and please ask. It will be a very informal meeting, and I don't think so that any one of us has to talk too much. I will try to finish this off in next 20 minutes. Next slide. So I'm thankful to all our panelists, Dr. Tejendra, Nikhil, Shivam, Prabhat, Satyajit, for being with us. Next slide. Yeah, these are our disclaimer. Next slide. So we'll start with our case, and there is only one case. This is a 58-year-old lady who had presented with a lump in the breast. An examination showed a 3-centimeter mass at 8 o'clock position. She has one child, and she had menarche at the age of 12 years. She has no other medical relevant history like family history. Next slide. Investigations revealed that she had a localized disease, and the metastatic disease was not there, and it is a T2N1M0. As you can see here, and ER/PR positive, Ki67 was 50%, and HER2, which was 2+ by IHC, confirmed on FISH as positive. Next slide. This is what the mammogram showed, that there were calcifications. Next slide. So yes, so let us now start with our panelists. Anyone can take up this question. If this patient comes to in your clinic, what would you do? Would you consider neoadjuvant therapy, or would you consider surgery and going ahead with an adjuvant therapy? So Dr. Imran, Dr. Tejendra, anyone, Dr. Satish, please go ahead.
I think,
Just your
yeah. So
Yeah.
this is a HER2 positive disease with a nodal disease. I think first thing we will try to see if we can clip the primary breast mass, and possible to do the FNAC of the lymph node, we'll do it. And so prior to nowadays, I have started doing the clipping of the primary breast mass. I do get a FNAC of the lymph node, and clipping the lymph node is a different question. We'll not get into it, but
Right.
there are some centers we have started doing the clipping the node also. But you
Yeah.
know, for all this clipping, the cost goes up. But you know, there are people who have done a lot of other things. But clipping a node is a controversial thing. But clipping the primary breast is something very common. So and question does come into about neoadjuvant. Yes. Second question which you asked is which neoadjuvant
that will come to later.
Yeah.
Yeah. Yeah. Anyway, you can answer, Tejendra. Yeah. Which of your is your favorite neoadjuvant?
I normally prefer going for non-anthracycline based. Only in a young lady with heavy nodal burden, I do think about giving anthracycline based chemotherapy. But day by day, my practice is changing towards going for trastuzumab from day one for every one of the patient, non-anthracycline based.
So you would use trastuzumab or with trastuzumab with pertuzumab?
Question comes about is if naturally the cost is an issue. If cost not is an issue, then I go for TP CH.
Right. So any of our panelists disagrees with that? If one thing is, Dr. Tejendra said that, yeah, neoadjuvant therapy, and he would prefer to use trastuzumab, pertuzumab with a non-anthracycline or anthracycline-free regimen. So any of our panelists have anything else to say?
Agree with the same, basically.
Sir, I agree with the same.
Yeah.
Okay.
Agreed, sir.
Nobody would go ahead with the surgery and this. Perfect. I think so. All of us agree with that. Let's go to the next slide. So this is just a slide showing that initially we used to use adjuvant therapy, neoadjuvant therapy for advanced breast cancer who are not suitable for surgery. Nowadays, even for patients who are locally advanced, is in whom we want better results with surgery, we go ahead. Even with for operable early cancers, we would go ahead with neoadjuvant therapy. Next slide. So this is what has evolved, and we know why we use neoadjuvant therapy amongst all of us are medical oncologists. We know for early assessment and response assessment to enhance the surgical option and for early systemic treatment, which we can give to our patients. Next slide. To treat the early metastasis. This is what I think so Dr. Tejendra was telling us on the basis of Neosphere study, that is all HER2 positive patients who had locally advanced disease or inflammatory breast cancers were randomized into 4 groups, that is docetaxel, trastuzumab, pertuzumab, or basically paclitaxel with trastuzumab, pertuzumab, or docetaxel, pertuzumab, or it was trastuzumab, pertuzumab 4. And the primary endpoint was comparison PCR, and the secondary endpoint was PCR in breast and nodes. So our next question will be, and after that, of course, surgery. This was obviously in all chemo patients. So basically, it was docetaxel, trastuzumab, docetaxel, trastuzumab, pertuzumab, or only trastuzumab, pertuzumab, or so it was mainly the arm B where docetaxel, trastuzumab, pertuzumab was done. Next slide. Next slide. So here you can see arm B where docetaxel means taxanes, trastuzumab, pertuzumab was used, had a TPCR. TPCR means breast and node, both showing pathological complete remission. In situ carcinoma is allowed. In Trifina study, which was mainly a toxicity trial where anthracyclines were given along with trastuzumab, pertuzumab, and they did not show excess of cardiotoxicity. Some or the other, here you can see the pathological CR rates, which are slightly higher than what we see in the Neosphere study. Next. So everybody, what is our panelist viewpoint? Do you take pathological CR as an endpoint? Or do you think there should be another endpoint which would be useful for us?
So it depends upon what type of breast cancer we are treating. In triple negative breast cancer, the correlation with overall survival is highest in with PAT-CR. For HER2, it is there. For ER positive breast cancer, we are not still able to show PAT-CR correlates with our outcomes. So it depends upon what type of breast cancer we are treating, rather than a single group of patients.
That's right. So I'll show you the follow-up study of 5 years follow-up of Neosphere. Next slide. This is a 5-year follow-up of Neosphere study where those patients who had undergone what we call as total pathological CR, that means in the breast and in the lymph node, their PFS was much better than those who did not undergo PCR, pathological complete response. Next slide. And as you can see, the hazard ratio was also quite significant. Similarly, in Trifenia study, they showed that this pathological CR was stratified as per hormone status. If you see, irrespective of ER/PR positive or negative, pathological CR rates were much better if trastuzumab, pertuzumab was given as a combination along with chemo. So regardless of hormonal status, pathological CR rates were good. Next slide. So this was the question which I wanted to ask, and we have already answered that pathological CR is an important endpoint, provided it is seen in patients who are HER2 positive or triple negative, where we see as pathological CR as a good event. If not, what is the alternate endpoint that you would prefer? Any one of you can answer this, please.
We obviously, as we have discussed, the PAT-CR is one of the corroborative endpoints. If
Right.
not, then overall survival, I would like to keep as my primary endpoints in curative settings.
That, I think so. Everybody agrees to that. We would like to see always overall survival benefit in all our patients. And absolutely true that the overall survival benefit would be another event which we would like to see, a positive event. Next slide. So this is what, as I told you, that most of our studies here show that pathological CR, and basis of pathological CR also, many times a drug is approved by the US FDA or our FDA. And this, as I showed you, that there is BPCR, TPCR. This is in breast PCR, or when in breast and node, it is called as TPCR. And the German groups are still more strict in that they don't want any in situ element also, and absence of invasive and in situ carcinoma in the tumor and axillary node is as per the German breast group pathological CR. But what we have taken in Neosphere and other studies is TPCR as total pathological CR. Next slide. This is again a pooled analysis of all neoadjuvant studies where they have shown all neoadjuvant where they have used trastuzumab, pertuzumab with chemotherapy. And here they have shown that in all patients, irrespective of hormone status again, that achieving a pathological CR in a HER2 positive patient, the event-free survival was much better. Next slide. So Trifini also told us the same thing, that irrespective of hormone status, pathological CR occurred when we used trastuzumab, pertuzumab. And these are just the guidelines which all of us know, that NCCN guidelines also tell us for all HER2 positive or triple negative, we should use neoadjuvant therapy, especially if it's a T2 tumor or a node positive disease. ESMO guidelines also tell us something very similar, that all HER2 positive patients or triple negative, we should be using neoadjuvant therapy. There's all other studies also, as you can see, St. Gallen's and the gynec oncology group also has told us very similar things. Basically, it is that all patients who have a T2 or a node positive disease should undergo a neoadjuvant chemotherapy, preferably if they are HER2 positive with trastuzumab, pertuzumab. Next. So this is just a flow chart which I would like to show you, that in newly diagnosed HER2 positive patients, T2 or N1 positive, there is required chemotherapy plus trastuzumab, pertuzumab. If it is T1C, they may undergo surgery for HER2 positive patients. If they are node positive, depending on the affinity trial, one would consider trastuzumab, pertuzumab based therapy. If node negative, we can just consider trastuzumab, pertuzumab that we give weekly doses of 12 weeks. And for those whom we have used trastuzumab, pertuzumab and undergo surgery, if they have pathological CR, we would consider using trastuzumab, pertuzumab only to complete totally 8 cycles, or if there is a residual disease, TDM1, as we know. Things may change in future also, from TDM1 to the next drug that you all know of. Next slide. Now coming to FESGO. This, I think so, we have just heard from, next slide. So we all know that the loading dose has a 15 ml solution and the maintenance is at 10 ml, and the loading dose has 1200 milligram of pertuzumab and 600 milligram of trastuzumab, and the maintenance is 600, and that is just a 10 ml solution given along with hyaluronidase. Next slide. So we'll just ask our panelists, any one of you all have used FESGO, and in those patients whom you have used FESGO, what is your experience with that? And did you face any challenges while using FESGO? So all of our panelists can say a few words for that. Yeah,
Sir, I have used FESGO. I'm Shivam, sir. I've used FESGO in few patients,
Yes.
and I have a good experience. Only thing is that the injection we have to, it takes a lot of effort in the arm, in the hand to push that injection. But otherwise, patients are very happy, sir.
Right.
The cost is less and the time is less.
Very true.
So I think one thing is that we are now shifting our most of the patient from the regular to the FESGO, but it doesn't come without any side effects. I'm facing basically rashes around the area, and your staff needs to be trained, because if you don't give time, suddenly push it and go away, it's not good. Ideally, it should be slowly given over a period of 10 to 15 minutes, because most of the subcu doesn't take time, but this takes time. Second concern, which is around the injection site rashes, which do happen, but they are all transitory. Normally, they settle down in few hours. So the advantages are too much. I think it's just a matter of time, I think, because our staffs get more further trained, nothing else.
Any of our panelists have seen rashes around that usually? Other ones, Dr.
Yes, sir. So,
Prabhat here, sir.
so there
Yeah.
has been rash.
I agree with Dr. Tejendra, sir. No,
Yeah. There have been episodes of rash around the side. Yeah.
Yes, sir. And those but have been mostly transient. I think Tejendra sir said it very correctly. Like any new drug, it requires a little training and getting used to. So
Right.
the first time effect is what is the issue. But and asking patient to wait for half an hour and 1 hour at least to before after the injection.
Right.
That is, and not telling the daycare sisters to, we are still giving it in daycare, but to shift the patient and not to shift or take a new patient in the same year. That's the only issue I face.
Right. So these are, I think, so initial teething problems. I'm sure
Yes.
once we are more confident of this, we will be not using, means we'll not be waiting for too long for the next patient to take in. These are some teething problems. Initially, we are also new to this product. So I'm sure with over time, we'll get used to it, all these teething problems. Thanks. Next slide, please. So this is the Frederica trial, which has already spoken, our previous speaker, and this is the investigators. So this was after giving adriamycin cyclophosphamide. They had paclitaxel was given IV. Paclitaxel with trastuzumab pertuzumab was either IV or subcutaneous, or docetaxel, and followed by surgery. And their stratification factors were hormone receptor status, clinical stage, and the primary endpoint was non-inferiority at cycle 7, pre-dose cycle 8, with the pharmacokinetics seeing the trough level. Next slide. And here you have seen this already, that the trough level were in fact better, a little marginally better, I would say, with subcutaneous rather than with IV. And the secondary endpoint was also in the fixed. We can see the serum trough levels were slightly better, in fact, with the subcutaneous version. Next slide. So these are some of the conclusions that were driven from the Frederica trial, that the trough levels were quite good, and the TPCR rates were also very much identical with trastuzumab pertuzumab, and we know the safety profile was nearly equivalent. There were no new safety signals that were identified with this IV formulation, with the subcutaneous formulation. Next slide. So these are some questions which Roche would also want to know from our panelists, that right now, whichever patients you are using intravenous pertuzumab, trastuzumab, any one of them, would you try and convince those patients to use the subcutaneous version?
yes, sir. I would definitely want to convert my patients from intravenous pertuzumab to subcutaneous, especially when there is ease of benefit and patients don't have to get admitted for a prolonged period in daycare. And when they are on maintenance therapy, they don't need an IV chemotherapy drug. So without an IV, things just with one prick, whether it is IV or subcutaneous, and with less time, why not to shift?
What
Yes.
does other panelists also would like to say?
Definitely. And along with that, you also get.
Yeah, sorry, go ahead.
So along with that, you also get the advantage of innovator trastuzumab also. So
Yeah, that is also
why
there.
not to shift?
Very true. But what happens, because most of our patients have a port also, because we had started them with intravenous. So what do you do with the port then?
Port you keep it, no?
Yeah.
Till what time?
Yes,
So there is no answer to how much time to port keep, but I think, before that, they never brought the trastuzumab in a subcutaneous formulation. They came up directly with a combination. So I feel strongly, I don't know what was the strategy of bringing only one, not a why to bring a combination, not to bring only Herceptin as a one. I agree. The talk is that 30% reduction, you get an innovator Herceptin, but somewhere down the line, still it is costlier than a biosimilar one. Now you might get the biosimilar in 8,000 rupees also. So I don't know how long the patient will be able to get convinced. Yes, most of the patients who have a good backup insurance, we are shifting them to the combination of ESCO. But I still feel it's a long way, still a long way forward before we can use it in a mass way. Because the biosimilar, the cost is going down drastically. It will, I don't think, sir, port, we should remove it. This patient's pocket might be over, he will require port again.
Yeah, I think so. That's very right. I think so. Most of our patients do have a port, and I also feel that we should keep the port. God forbid, at some point of time, if we require it.
And I think there is one question which I just want to ask. Those patients who are already on biosimilar, shifting them to Phesgo, do you find any added advantage of giving pertuzumab, sir?
If they are only on trastuzumab,
well,
if they have a heavy tumor burden, it may be worth.
And they are doing well with the trastuzumab.
Adjuvant or neoadjuvant?
In a metastatic, I'm just putting, not adjuvant. And also in adjuvant setting, I'll just say.
Yeah, I think so. It may be worthwhile because the data is there for adding pertuzumab, you'll get benefit.
Right now, we are not seeing any side effects, extra side effects. That's it.
Yeah, pertuzumab, I have seen few patients lose stools. That is all what I have seen when adding pertuzumab, trastuzumab. One or two of my patients in the beginning got loose stools. Otherwise, most of them, means adding pertuzumab, no additional side effects.
No additional side effects. I think, but if the affording patient, we are giving option. But I feel the biosimilars cost is also going down drastically, and it will. I think the next 6 months we'll see a drastic drop also.
So all of our panelists agrees that they would try to convince those patients who are on transfer IV to go on for subcutaneous for want of time, for better treatment option, which we feel that this is more of a newer version. So let us try this. Next slide. Anything else is there? This we already done. So what we saw in the other trial also the same thing, that when the patient wanted to be shifted from the previous slide. Next slide. No, previous, sorry, previous slides. Yeah. So this was the Francisca trial where, initially they gave IV, and this is what we were discussing, and then they switched over to subcutaneous, and the one whom they started on subcutaneous were switched over to IV, and the patients were asked which is better. Next slide. This is the Francisca trial, and the patient's preference was the primary endpoint. And as you can see, most of the patients preferred subcutaneous over IV. So patients also wanted lesser time to be in the hospital and did not mind a prick of a subcutaneous prick. And obviously, we all know the advantages that less time in the clinic, they are more comfortable during administration. And from this Francisca trial, 87% of the patients chose to use subcutaneous instead of IV. Next slide. And as we all know, now Phesgo being more economical than the IV pertuzumab, we all would prefer to use in that way to help our patients. Next slide. And these are just to show a few of my patients who are right now on Phesgo, who are previously on IV, and many of them have switched over to subcutaneous version. Most of them are in the metastatic, and the neoadjuvant only there is one patient whom I have kept. Otherwise, most of them are metastatic, as Dr. Krishna said. Next slide. And I would now hand over to Rosh. And thank you very much, all our panelists, for being with us.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you so much, sir. If any of your audience members has any question, we request you to please raise your hand or put the question in the chat box, and we would request our esteemed moderator to please take it up, sir. So we'll wait for another minute. If anyone has any questions, you can just raise your hand and we'll unmute you. So, sir, I believe we don't have any questions. Thank you so much for a wonderful panel discussion. So with your permission, we'll move on to our next session.
Yeah, thank you.
So we'll move on to our next session. This session is sponsored by Gene Evolve. And our esteemed speaker is Dr. Vamshi Krishna T. He is the head of genomics at Dr. Lal Path Labs, NRL, Delhi. And he'll be talking on the topic molecular signatures of drug-resistant HER2 positive breast cancer. With that, I invite Dr. Vamshi to please deliver his lecture. Over to you, sir.
A very good evening. Can you see my screen?
Yes, sir. We can see your screen and also hear you, and we can see you as well, sir.
Right. Thank you. Thank you so much. A very good evening to everyone. It was a wonderful, brainstorming panel discussion that we just had. I'm just going to take you back to the basics and maybe a little bit towards what we can do better in terms of resistance. So my talk is about molecular signatures. Molecular signatures of drug resistance HER2 positive breast cancer. So breast cancer, basically, the gene expression 5 subtypes: luminal A, luminal B, basal-like, HER2 overexpression subtype, and normal breast subtype. Why is HER2 overexpression subtype important? Because overexpression amplification happens in about 20 to 25% of primary invasive breast tumors. It pertains to aggressive disease, and there is negative patient outcomes that we can look at. HER2 is one of the 4 transmembrane protein tyrosine kinase receptors: HER1, 2, 3, and 4. HER1 is also called as the EGFR. So basically, there is dimerization of the receptors. HER2 dimerizes with one of these, activates the downstream signaling pathways in the form of PI3K kinase pathway, the RAS pathway, or the JAK-STAT pathway. This would lead to gene expression, the cell proliferation, cell survival, as well as metabolism in the form of differentiation, proliferation, apoptosis, and metastasis of these tumor cells. The first HER2 targeted medication authorized by FDA was a humanized anti-HER2 monoclonal antibody, the trastuzumab. And trastuzumab and pertuzumab, they bind to the extracellular domain 4 of HER2. They inhibit the formation of homodimers and blocking the generation of downstream signals. It significantly improves the disease-free survival. However, 25% of these early stage diseases will relapse within the first decade of trastuzumab treatment. The first line standard, as was mentioned by Dr. Shivam, the first line standard of neoadjuvant therapy for HER2 positive breast cancer would be a dual HER2 targeted combination of pertuzumab, trastuzumab with a cytotoxic chemotherapy, like, for example, docetaxel. But it has shown an 8-year survival rate of only 37% in HER2 positive metastatic breast cancer. There are certain resistance mechanisms that we need to look at. The second generation humanized monoclonal antibody, the margetuximab, has been approved by FDA for use in combination with chemotherapy for treatment of previously treated metastatic HER2 positive breast cancer. It increases binding to the CD16A and decreased binding of CD23B, which leads to an increased natural as well as acquired anti-HER2 immune responses. So what are the resistance mechanisms? 1, downregulation or loss of the HER2. 2, high expression of P95 HER2. I'll come to that. And 3 is PTEN loss. So when there is a PTEN loss, it leads to impairment of this signaling pathway. With P95 HER2, it is an amino terminal truncated form of HER2. It is highly tumorigenic and it lacks the trastuzumab binding ectodomain as well as the HER2 kinase domain. There is a mutation which is S310F, which forms in the subdomain 2 of the extracellular domain of HER2. It affects the binding of pertuzumab to HER2. So this substitution will lead to pertuzumab resistance, and this mutation does not affect the anti-HER2 effect of trastuzumab. So the antibody drug conjugates trastuzumab with DM1. This conjugated antibody is for the treatment of trastuzumab resistance patients. It combines trastuzumab with the cytotoxic medication DM1, which is a microtubule polymerization inhibitor. And this is internalized in the cells, and this inhibitor payload can be cleaved from the antibody. So this acts directly on the cells which overexpress HER2. So the acquired DM1 resistance nearly always occurs in the first responders. Trastuzumab resistance as well as the anti-microtubule drugs may contribute to this resistance. However, the genetic weakening of the lysosomal membrane protein SLC46A3, it inhibits the potency of TDM1. Here, I would like to introduce the concept of caveolae. So we understand from our physiology that caveolae are highly hydrophobic membrane structures. They are vesicular, hollow, 50 to 100 nanometers in diameter, and they account for 20% of the cell membrane area. So they are involved in the classical process of of endocytosis. Caveolin 1 is a key protein for this biogenesis and function. And this upregulation of caveolin 1 enhances the sensitivity of HER2 positive breast cancer cells to the TDM1 that I was mentioning before by promoting endocytosis of trastuzumab. Expression level of caveolin 1 can serve as an intrinsic biomarker for the sensitivity of this HER2 positive breast cancer cells to TDM1. Trastuzumab deruxtecan, DS8201, is a second generation antibody drug conjugate for targeting HER2. It comprises a different payload than its previous predecessor. It mediates low HER2 expressing cells to circumvent the resistance mechanisms. Destiny Breast 003 trial, phase 3, has shown that DS8201 has significantly reduced the probability of disease progression or death when compared to its predecessor, the first generation, TDM1. What are the small molecule tyrosine kinase inhibitors? As we all understand, protein tyrosine kinase inhibitors are used in various hematolymphoid as well as solid tumors. These bind to the intracellular ATP binding domain of EGFR. They inhibit the tyrosine kinase phosphorylation, and so they block the downstream signaling pathway. Three of these, lapatinib, neratinib, and tucatinib. Lapatinib is the first clinically approved HER2-directed tyrosine kinase inhibitor. It's a dual reversible tyrosine kinase inhibitor of EGFR and HER2. It selectively inhibits the HER2 amplified cells, both in vitro as well as in vivo with trastuzumab. It causes cell cycle arrest during the G1 phase, and it prevents proliferation of breast cancer cells that overexpress the HER2 gene. Neratinib is an irreversible HER1, 2, 3, 4 tyrosine kinase inhibitor. It covalently binds to specific tyrosine residues, the 773 and the 805, in the ATP binding pocket of the reversible tyrosine kinases, and inhibits the tyrosine kinase activity of all the HER1, 2, 3, and 4. When it comes to tucatinib, it is a specific and reversible inhibitor of HER2 tyrosine kinase. It has been approved by FDA in 2020 in combination with trastuzumab and capecitabine for the treatment of adult patients with advanced unresectable or metastatic HER2 positive breast cancers. HER2 mutations occur in about 3% of cases of exon 19, the L755 allele, which encodes the intracellular domain of tyrosine, being the most common. It accounts for about 22% of mutations. And HER2 L755S is not only completely resistant to the dual regimen of lapatinib and trastuzumab, but also to the regimen of the ADC combined with lapatinib. So there are various signaling pathways that have initially shown, and what is the resistance to these HER2 targeted therapies? The PIK3-mTOR pathway, which is involved in cell growth, cell proliferation, cell metabolism, apoptosis, and angiogenesis. More than 30% of the invasive breast cancer, they involve the PI3K and the AK3 mutations. So everolimus is an mTOR inhibitor, and it is the first non-HER2 targeted therapy to address the underlying mechanisms of trastuzumab resistance. Bolero 1 trial, it has added everolimus to the combination of trastuzumab and paclitaxel, and a 7-month progression-free survival benefit was seen in these HER2 positive advanced breast cancer patients. When it comes to the insulin-like growth factor, the proliferation and survival of the HER2 positive breast cancer cells are usually inhibited by the negative feedback inhibition of this. So if you target the IGF, it will effectively overcome the trastuzumab resistance. Zentuximab is a humanized IgG1 monoclonal antibody, which has been used against IGF-1 and F2, and it has demonstrated effectiveness in numerous tumor models. It is currently undergoing clinical trials. The transforming growth factor family of proteins, has a functional interaction between HER2 and them, and there is a breast tumor resistance to chemotherapy and HER2 targeted therapies because of this pathway. What about the tumor microenvironment? So the tumor microenvironment includes immune cells, extracellular matrix, as well as interstitial tissue along with the cancer cells. The higher the tumor infiltrating lymphocytes, it has been shown that there is a higher overall survival rate. PD-L1, PD-1 is an essential immune checkpoint. The combination of PD-1 and PD-L1 can induce apoptosis, and it inhibits the immune response in the tumor microenvironment. By stimulating these immune effector cells to release the interferon, trastuzumab may increases the level of PD-L1 in the cancer cells that overexpress the HER2. So there is a resistance to trastuzumab in this anti-HER2 therapy. By giving the anti-PD-L1 or the anti-PD-1 antibodies, these block the interaction of PD-1 and PD-L1 and can reverse the inhibition of CD8 positive T cells, and it would enhance the anti-tumor activity. So Mittal et al. Demonstrated that anti-PD-L1 therapy could significantly improve the anti-HER2 therapy, which is given in HER2 positive breast cancer patients. I've come to the conclusion of my slides, and I would like to conclude by saying that upregulation of HER2, abnormal activation of HER2 downstream signaling pathways that I've mentioned, deletion of any tumor suppressor genes, cell cycle dysregulation, and low infiltration of the tumor immune cells. These are all the causes for for the resistance of treatment in these HER2 positive cases. And selective inhibitors of PI3K, inhibition of the insulin like growth factor signaling pathway, and CDK inhibitors. These can sensitize the HER2 positive breast cancers to anti-HER2 therapy. And research is ongoing on this. This is the last slide I would like to show to you. Here, if you can look at the anti-HER2 trastuzumab, the ADC inhibitors which act on the HER2, the anti-PD-L1, the immune checkpoint inhibitors in the form of atezolizumab, and pembrolizumab. The lapatinib, these are the salt tyrosine kinase inhibitors that we look at. The PI3K inhibitors, alpelisib, and others. And as I was mentioning before, the mTOR inhibitor everolimus has been added, to inhibit the mTOR, to cause the mTOR mutations, which would lead to non-HER2 treatment for these patients, and CDK inhibitors in the form of palbociclib and others. These are the FDA-approved HER2 targeted therapies, the monoclonal antibodies, the anti-drug conjugates, and small molecule TKIs. However, the others can be probed into these resistance mechanisms for HER2 targeted therapy. Thank you so much for your attention, and that would be the end of my talk. I would questions.
Thank you so much, sir. If you have any questions from our audience, we request you to please put them in the chat box, so you can just raise your hands. If any of our panelists also have any comments or any questions, please feel free to ask them.
I would also share my email ID, and if you have any questions whatsoever, I would be willing to sort of give the answers via email as well. So
perfect, sir. You can put your email ID in the chat box. Thank you so much, sir.
I'll do that. Thank you so much.
Thank you so much, sir. So with that, we come to a close of the session. So thank you, everyone. Thank you to all our participants. Thank you to all our faculty members, and a big thank you to our supporters as well, Roche and Lal Path Lab. With that, we come to a close of the session, and we hope to see you soon in our future endeavors. Thank you, everyone.
Thanks a lot.
Thank you, sir.